Good day, everyone. My name is Kava. I'm one of the emergency physicians, and this is the first video that I'm creating for ultrasound training. The series is called Ultrasound for Dummies, and I hope you can learn something out of it. Technically, the reason I'm making these videos is because point-of-care ultrasound now is part of the curriculum of many subspecialty training programs, including emergency medicine. So this is just for beginners to have an idea of what ultrasound is and what you need to do. Today we're going to talk about BELS or FELS, which is echocardiogram in life support. Right. So, used to be traditionally called BELS, and now it's called FELS, as in focus. So BELS as in basic echocardiogram in life support, or focus echocardiogram in life support. First thing is first, you need to answer 5 questions. If you answer these 5 questions, that's enough, and you don't need anything else. Number 1, is there anything beating? Yes or no? So for many of us, it's very difficult question to answer, saying that the patient is coming into cardiac arrest and everyone is checking the pulse, they're in PEA, is there a pulse, yes, no, putting an ultrasound, is there any organized cardiac activity? So first is first, so breathing, yes, no. That's a yes, no question, yeah? Second, how is the LV function? Okay, we go through the details of that one. Third, RV. It's going to be a quick assessment RV. 4, is there any pericardial effusion? Again, this answer to this question is a yes or no, and if yes, you need to clarify, is it a large effusion, is it a small effusion, has it affected the heart function or not? And number 5 is IVC. Okay, so these questions, an answer to these questions will formulate what we call BELS or FELS, and you can make a comment about focus echocardiogram in life support. To be able to achieve these questions, you may need to have at least two axis view of the heart, at least. It's very difficult to understand. A lot of the times in resuscitation rooms, it's very, very difficult to have all 4 or 5 axis views or different views of cardiac echocardiogram, and most of the times you only can just look 1 or 2. So my suggestion is, if you can answer any of these questions, you tick and you go to the next, but a lot of the times you need more than 1. Okay. We can talk in another video how we achieve 5 views and put it on the channel. So LV function, you need to answer 1, hyperdynamic. 4, LV dysfunction. 4, grossly normal. Hyperdynamic is when LV walls are kissing each other. That's very important. Important to differentiate between tachycardia and hyperdynamic. LV dysfunction is when LV is not moving much, okay? It's sometimes very difficult to assess, and actually it's a technical thing to assess ejection fraction or other methods to check LV function. All I want you to know is you need to clarify whether it is mild to moderate or moderate to severe dysfunction. So mild to moderate. moderate, and then moderate to severe. Yeah? Okay. Grossly normal. Grossly normal is normal functioning LV. With more videos, we'll show you what is normal and an easy way to assume it's a grossly normal LV function. RV. What are we after in RV? Is RV enlarged or not? So RV size normally should be not more than 2/3 of LV. And septum should be always moving away from LV. If you have an RV like that, that's your RV, and that's your LV, and that's the septum. Septum should always go away from LV. Remember, LV is a high pressure system, RV is a low pressure system. So septum should always be going away from LV. If septum is not going away from LV, or the way around, septum is basically going towards LV, that's called septal bowing, and that's showing the pressure in RV is increased. Or alternatively, the size of RV is increased. This is the size, yeah? This is based on the septum, this is based on the size. And you can see LV is affected because of the high pressure of RV and the massive size of the RV. These are consistent with basically RV dysfunction and possibly an obstructive shock. Yeah, someone should run for this. It's not me today. So, there's another way of assessing RV, which is called TAPSE. And TAPSE is based on, you see that's the lateral triplet of tricuspid valve. Where how much it goes up and down is important. We can talk about TAPSE later, but basically it has to go up and down more than 1.6 centimeters to say that RV is got a normal systolic function. So LV, systolic function, is based on squeezing. RV is based on going up and down. RV is a low pressure system versus LV is a high pressure system. So remember, you won't see the squeeze that you see on LV on RV, so you won't see the squeeze. The only thing that's showing us the systolic function of RV is normal or not is whether it goes up and down. Could be acute, could be chronic. Pericardial fluids. So anywhere above 2 centimeters is assumed as large. It's very important to know in how long this effusion has happened. If 1.5 centimeters effusion happens over years, it's not going to harm. But if 1.5 centimeters effusion happens in few hours, it can collapse your RV. Why? Because as I told you, RV is a low pressure system. So if you've got a effusion there, and that's your RV, and that's LV. So LV is got high pressure, so it doesn't collapse, but RV is a low pressure system. It can collapse. So a heart is not receiving fluids, hence cannot produce some output. Preload, no afterload. That's another type of obstructive shock. So that is called, as we know, tamponade. Above 2 centimeters is always to be considered as an important clinically effusion. Also, if you see that RV collapse, that's important as well. How about IVC? There are many talks about it. More than 2 centimeters, more than 1.7 centimeters, more than 1.5 centimeters. The sweet spot I found in most of the talks and most of the literature is 1.5 centimeters. My apologies, 1.7 centimeters. So if IVC is above 1.7 centimeters, it is filled properly or plethoric. If it's below 1.7 centimeters, it's underfilled. The other parameter you measure is in inspiration and expiration. What is the size? What's the difference? What's the percentage that it collapses? So it's called collapsibility. If it is more than 25%, either normal or high collapsibility. If it's below 25%, it's abnormal or less collapsibility. So IVC, if it is plethoric, saying 2 centimeters, and it's not collapsing, that's showing your patient's likely fluid overloaded. But if it is, for example, 0.5 centimeters, completely collapsing, your patient is likely empty. Answering these questions, beating yes, no, LV function, RE, pericardial fluids, yes, no, and how much. Is it significant or not? And IVC, what is the size, what's the collapsibility? Will likely give you an answer about your patient's fluid status. Later on, we can in detail talk about fluid status and the importance of doing a long ultrasound at the same time. Hope that answers some of your questions, and continue following us.